my goal today is that we're really understanding the scope and nature of methamphetamine use, consequences and interventions, get an answer to a question you've had, get a new question you didn't even know you had, meet all those fabulous people who know how to raise their hands multiple times, and walk out of here with an action step or 3 that you can do something meaningful with. So the scope and impact of this is large and growing across the state, and the reasons are complex, and our responses are therefore going to have to be really comprehensive. I saw this graphic on Twitter, and I didn't know how to acknowledge it except to say it's on Twitter, which is not a very good citation. But I think this is the stylized graphic I think that really represents that we're often kind of looking at the tip of the iceberg, and clearly you're not understanding or dealing with the whole situation if you're just dealing with what's up top. And there are massive substantive things going on in our society and within individuals that are really driving, reinforcing what we're seeing in terms of problems related to methamphetamine use. Here's an unstylized graphic. This is my walk to work yesterday. And what I think you can see here is you got the highway with people zipping by and going about their business, and maybe they're glancing up and seeing those tents sitting up there. And you can see that crane in the background. We're gonna have at least a half dozen, I don't know how many. Many 2-dozen-story buildings are popping up in our own neighborhood right here. You can see residences, and the second building on the back is the University of Washington Tower. So you can kind of get a sense of what are all these things going on, these interrelations that are going on, people paying attention or not paying attention right in our own backyard. So there is a growing body of research in this area. There is no gold standard treatment for methamphetamine use. A lot of interventions do work for a lot of people, and you'll be hearing about that today. So I really encourage you to listen out for what you can use now, what you might be able to use in your work down the line, opportunities and ideas for novel implementation, new things we might want to try, and gaps that you want to help address. So the providers of all these services, primary care, behavioral health, harm reduction, and social services, they play really important roles in collaborative solutions, and particularly given, I think, what we're learning about cognitive functioning for people with sustained methamphetamine use disorder. For people with serious cognitive impairment, we know people can return to normal functioning, and we also know that it can take 6 to 18 months. That's a long time to figure out how to really support people and engage them when they still don't have all the tools that they need to be able to reach out back and engage with other people. So there's just a lot of work and sustained work we need to be able to do at the front end, and then of course long-term as well. And then our partners and colleagues in law enforcement and criminal justice, they're also significantly impacted by methamphetamine use. And we need to work with them, and they need to learn how to work with us to really partner. Are there policies and programs and practices they can modify to reduce those harms and improve people's lives? I had the opportunity to talk with federal judges last year, and just explaining what substance use disorder was to them, they didn't even think about how their pre-sentencing decisions impacted a person with substance use disorder. They literally didn't know. I'm very thankful that people in this room, I think, do know and are very mindful and are working on those things. There's a lot still to do, also within the legislative realm as well. But these are really important partnerships we have to work with because we can either amplify or decrease harm with our choices. So really critical time right now, and you'll see some of the epidemiology around us to figure out our policy and research agendas. And we're also really kind of lucky and that we can leverage the programs and relationships we already have in place, particularly on opioids, homelessness, behavioral health, and criminal justice reform. There's a lot going on that intersects with this, and I think we need to leverage that and think more expansively about what we're doing. So again, here's what I hope you will take away from today. And I want to introduce, let's see, so I'm going to stay here. And I'm going to introduce Sally Clark, who's the University of Washington Director of Regional and Community Relations, and is a former city council member, and is a great partner, and we are working and strategizing, so I'm happy to have you here. Welcome.
Thank you, Caleb, and good morning, everybody. Oh, come on. You've got a day ahead of you. You're going to have to figure out these engagements. Good morning. There you go. I am Sally Clark. I do have the privilege of welcoming you here this morning on behalf of the University of Washington. I'm the director, what they call the director of the Office of Regional and Community Relations. So I work in external affairs. We generally aren't allowed to get near the students, which is fantastic. But I have the privilege of coming here every day, unless I'm working downtown, and working on behalf of the students, the staff, and the faculty of the university with the neighborhoods and the towns and the cities around in this greater region. I get to work with incredibly smart, talented people. They're compassionate, and they take their curiosity and the training out to tackle the world's challenges, and that's what you are doing here today. So I'm honored to be asked to be here to do the welcome. I touched something. Sorry, Caleb. We'll make it go back at some point. Yeah, that's right. Pay no attention to me. I think I'm going forward. Not that one? We'll just stay right there. We'll stay right there. All right then, moving on. We are grateful that you've chosen to be here with us today. Really appreciate it. For some of you who work in academia, and actually seeing the hands that go up, there aren't that many of you who work in academia, but this is the start of a little bit of a break for you. University of Washington just started summer quarter right now. But you're here today, and we in the state, we in this region, we in the U District, we need you. We need everything that you're bringing here today. I have my official role with the university, and that makes me happy to be feeling like I'm some small part of the work that's going to happen here today, understanding and treating meth addiction and its impacts. And in my previous job, as Caleb mentioned, I worked as a Seattle City Council member, and as that work allowed me to do many things, it allowed me to serve on the Board of Health for King County. Also, I got to serve with the Association of Washington Cities, and in both of those examples, I can't think of one person I worked with who couldn't say that their communities were being affected by meth. Some of them didn't really understand really well why and how and what to do about it, and felt very alone and unable to figure out what the right steps were, frustrated, under attack sometimes. And everybody had a story about how meth's manifestation and impact in their community was corrosive for their community. And they all of us continue to struggle with how to fix these things. So today you all come together to learn more about how meth addiction is presenting in different populations, what interventions are working and for who or whom, what's complicating treatment, and I hope that you'll identify some of the things that Caleb just mentioned. I hope that you're going to identify needed policy and research paths that will help us address those gaps in services interventions. You've got the right people in the room, and you've got people listening for what you need. Peeling back all the layers, though, all of us sitting here today, we're friends, family, and neighbors to people in crisis. For me, that's often what I see around the U District, but also that's the close friend that I have from a couple of decades ago who fell into headlong meth addiction. And like in so many cases, what followed was job loss, chaos with family and friends, illness, bankruptcy, and continuing cycles of that. Unlike in so many cases, though, he's doing really well today. He had a network, he had support, the things fell into place for him. He's in recovery, he's working in a job he loves, and he's deeply in love with his life. So again, on behalf of the University of Washington, I want to thank you for the work that you're doing and for choosing to be here today. Now let's go forward and inform some new policy and research. Thank you.
So next I want to invite up Dr. Charissa Fotinos, who is a colleague and friend who works at the Washington State Healthcare Authority and Division of Behavioral Health and Recovery. She's in the medical director's office at the Healthcare Authority and also serves in that role at the Division of Behavioral Health and Recovery. And I think also importantly, in addition to working at the state level, has served as the medical director for Public Health Seattle King County in the past, and also been working on things like the mobile medical van. So has a really good sense, you go from 5 feet to 50,000 feet really well, and I appreciate that. So I'd like to welcome Dr. Charissa Fotinos.
Thank you, Caleb. Good morning, everybody. You know, I thought about where to start, and I think I'm going to start with my sort of first clinical introduction to methamphetamine, and that was over 20 years ago when I was working at Providence Hospital at the time, and we had worked in concert with a Seattle Children's Home to set up a mobile medical program that came to the University District at night and went to Broadway and primarily focused on kids who were living homeless at the time. And that was really my first introduction to methamphetamine and the effects and the problems with chronicity. It wasn't nearly as potent as it is now, but clearly I saw things like people who'd been up for a week and then slept for a week and came in 20-year-olds with leg ulcers just because they didn't move for a week. And so really understood at that kind of unfortunately guttural level the effects of methamphetamine use. Opiates have been a little bit more noisy lately. Fortunately, at the state level, we've received a lot of federal funds to really think about how can we best address the opiate crisis. That said, as you all know who work with folks who struggle with substance use disorders, it's rarely just that people focus or struggle with one thing. Maybe it's opiates and cigarettes, maybe it's cigarettes and alcohol. So we have to think differently about how we approach this, both at the provider level, whichever kind of provider you are, the community service organization level, and certainly at the state level. We've been fortunate to be the recipients of a Medicaid transformation grant, and we've started to think about how we can better support both our providers of care in the broadest way that goes, as well as our communities. The accountable communities of health have been mandated to work on the opiate epidemic. But as it's evolved and we've seen this, we can't talk about the opiate epidemic. We have to talk about substance use disorders. It's been opiates. Right now, methamphetamine is the most urgent, but in 5 years, it'll be something else. So what we've been tasked to do and are tasking ourselves to do with my colleagues here in the room is, how do we go from a system that approached addiction that we need to just have people stop? That's how we do it. Well, I can't treat blood pressure that way. I can't give everybody the same pill. If I did, you wouldn't need doctors, we'd go to a vending machine, right? And as we learn more about precision medicine and what we need, maybe people who use opiates and methamphetamines need a different approach than people who use opiates and alcohol, or opiates and tobacco. We don't know that. That's what the researchers are here to help us learn. So I think we have to think about this both as an individual problem that everybody's going to require a little bit different type of help, that one size cannot fit all. So how do we move our system that was here's addiction, here's mental health, and here's clinical care to here's a person. And we have to talk to each other better, we have to communicate better, and at the state level, we have to help support that through the provision of interoperability and exchange of information. We have to make policies that don't get in the way of people doing their work. And we have to really work with our new partners in the managed care plans we're giving them a bunch of money to say, you guys fix integration, right? We're asking them to do a lot. So we have to know what that means. We have to be thoughtful. We can't have borders. We can't have boundaries. We are all in this together. If we're not listening to the researchers who are doing the implementation science and the practical, this works good in this case, we're not doing our job at the state. If we're not listening to the chemical dependency providers who are saying, look, this is the best combination when I see this, and you can't just pay for 30 days, you got to help us for years, then we need to listen to that. So I see this both as a frightening time, because every day I drive to Olympia, I see more tents in between the highway. I see more people struggling. So I see it. I live in this community. That said, it's an opportunity. We have federal people paying attention. We have money coming our way. Our legislators have been extremely helpful. They get it. They're supporting us. They've given us a lot of money to address this. So I see this as an opportunity in the face of an unfortunate tragedy. And I want to just end by saying the iceberg that Caleb showed, that's really what we're dealing with. Right now I'm going to stray a little bit. I was at a conference last week, and the gentleman who sort of discovered the whole ACEs phenomenon at Kaiser spoke. And he had an interesting thing that I didn't necessarily agree with, which was addiction is not a disease, it's a symptom. I don't think I agree with that. I think that addiction is often a pathway people find themselves on to quiet all the things that might be part of their troubled past, but it also can happen in people who don't. So rather than thinking about this disease, that disease, let's think about people, providing them hope, providing them empathy, and people who care about them. And we all have to work together to make this less of a crisis and more of a how do we help people be their most successful, healthy selves. So the state, we're here, my colleagues with me, we're listening, and we're hoping to learn a lot from you. So thank you very much.